Hello everybody, today we're going to be talking about language and lateralization in the brain. So in terms of lateralization, and we talked about this in the beginning of this semester, we have two hemispheres, the right and the left hemisphere, and they're not mirror images of each other. They look fairly similar, but they're not identical. Some areas are a little bigger on one side, a little smaller on the other. For the most part, the left hemisphere of the brain controls the right side of the body, and the right hemisphere of the brain controls the left side. Lateralization is the idea that the hemispheres are specialized for different tasks, that there's a specialization of labor between the two hemispheres. And in the biggest, broadest strokes, the left hemisphere is specialized for language, where the right hemisphere is specialized for visuospatial tasks and emotion. We're going to talk about this because it's not as complete as just left hemisphere for language, right hemisphere for visuospatial tasks, but in a big picture way. We can talk about it that way. Now, we have two hemispheres, and the two hemispheres are pretty much separate, except for the commissures, which are axons that actually connect the two hemispheres and exchange information. So let's see, the corpus callosum is the primary information highway, we could call it, between the two hemispheres. So if this is looking from the top of someone's head, imagine kind of slicing off part, unfortunately, of the top of their head and looking down. You've got here a left hemisphere, a right hemisphere, and you can see that they're disconnected. They really are separate, except for this bridge of axons that we call the corpus callosum, and these axons go left and right to connect and let the two hemispheres talk to each other. So without the corpus callosum, the left hemisphere could only process information from the right side of the body, and the right hemisphere could only process information from the left side of the body. And this corpus callosum allows the two hemispheres to talk to each other. There are other smaller commissures that do connect the brain in a few other spots, but this is the main one. And this is a side or sagittal view of the brain. You can see the corpus callosum here in purple. This is this bridge that connects the two hemispheres. So let's talk about lateralization in terms of vision for a minute. Sensory information received on one side of the body is usually processed by the contralateral. Contralateral means opposite hemisphere. So we've already said that sensory information from the right side of the body is processed by the left or the contralateral hemisphere, and information from the left side of the body is processed by the contralateral or the right hemisphere. So in terms of visual information and visual fields, here's our left visual field. Right here are the eyes. Someone's looking out here into space, seeing something out there in front of them. Information from the left visual field, and the visual field is what is seen or what is visible at any moment. And both of your eyes, your left and your right eye, see information from the left and right visual fields, right? The right visual field, information from the right visual field goes to the left half of your left eye and the left half of your right eye. Information from the left visual field goes to the right half of your left eye and the right half of your right eye. Okay, so right visual field, like we said, goes to the left half of both retinas. And then, and we talked about this in vision, if we're looking at the left visual field, it goes to the right part of the retina. Then this information from the outer part of the right retina gets sent here through the optic nerve and does not cross. It stays over here and is processed in the right hemisphere of the brain. and information from the left visual field that hits the left eye, the inner part of the left eye, comes out here through our optic nerve, crosses at the optic chiasm, and this information is sent to the right hemisphere. So any visual information from the left visual field hits the right part of both retinas and then is processed in the right hemisphere of the brain. And you can see with the information that's processed on the outer part of the right retina stays on the right and goes to the right hemisphere. Information that's processed or sent to the inner part of the left retina does cross at the optic chiasm and go to the right hemisphere. And then the opposite is true with the right visual field, right? The right visual field sends information to the left part of the left retina, the left part of the right retina, the part of the outer part of the left retina, information there does not cross and stays and goes to the left hemisphere. Information on the inner part of the right retina crosses and goes to the left hemisphere. These inner pieces, we always say the inner part of the retina or the more nasal part, right closer to your nose, those are the ones that cross. And the outer information from the outer portion doesn't cross. When you cut the corpus callosum, however, you prevent exchange of information between the two hemispheres. This is sometimes used as a therapy for very severe epilepsy. If you've got epilepsy, which are seizures or this uncontrolled electrical activity that is affecting both hemispheres of the brain and it can't be controlled by medication, sometimes they cut the corpus callosum, and so at least wherever the seizure is starting, if it's starting in the left temporal lobe, it can only stay, the seizure activity can only stay in the left hemisphere. It can't cross over into the right hemisphere and involve the entire brain. And so seizures only affect half the body and are less frequent. But when you do something like this, which is a very drastic measure, it creates what we call split brain behavior because people actually have two hemispheres that are no longer connected. And so in real life, your eyes are constantly moving around, and so you don't often notice any specific deficits due to this split brain surgery. But in controlled experimental conditions, you can actually see that the two hemispheres aren't able to interact. So, for instance, in a control participant who does have their corpus callosum, right, we talked about the left visual field sends information right to the right side of each eye and then to the right hemisphere. And the right visual field sends information to the left portion of each eye. The inner nasal axons cross, the outer don't cross, and again, this goes to the left visual, or the left hemisphere, and visual information is processed back here in the visual cortex. So if you have a person, a control participant, looking straight ahead, looking at this fixation point, this dot that's straight ahead, so they're only sending information from the left visual field to the right hemisphere and only information from the right visual field to the left hemisphere. And you show somebody a key. They look at a key. Then their left visual field, which again goes to be processed in the right hemisphere. The right hemisphere is not specialized for language, and most people, language centers are on the left side. So if we ask them, what do you see? Well, the information is sent from the left visual field to the right visual cortex, and then through the corpus callosum, it is sent to the left hemisphere to the language center, and the person says, key, no problem. Even though the right hemisphere doesn't have any language, although this visual information was sent to the right hemisphere, it crosses over to the corpus callosum and gets to your language center, and you're able to say, key. In a split brain participant, you have a different situation. So now we have a severed corpus callosum. There's no connection anymore between the two hemispheres. And I'll actually start here. In this case, if we show, again, the person is fixating their eyes on this fixation point. So the key that you're showing them on the right, in the right visual field, is only being processed. It's going to the left side of both eyes. The left outer part of that retina stays on the same side. Axons from the inner or nasal part of the right eye cross at the optic chiasm. And so information from the right visual field is sent to the left hemisphere, first to the occipital visual areas, then to the language area, and the person says that's a key, no problem. But if you show the key in a split brain participant, again, they're staring at the fixation point, in the left hemisphere, this information only is processed by the right hemisphere. They see the key, they know they're seeing something, but when you ask them, what are you seeing? The information doesn't transfer over. There's no way to get that information to the left hemisphere, and they can't tell you what they're seeing. And so this is a very specific setup where you see a difference in behavior and in the abilities of a split brain participant. Now, typically, when they're looking at the world, they don't have to keep their eyes fixed at a certain point. You're moving your eyes all around so you can see the key in your left hemisphere and your right hemisphere, and so it really doesn't affect their abilities, cognitive abilities, on a day-to-day basis. But when you set up a situation in a very specific way, you can see the lateralization, that when information is just sent to the right hemisphere, although they can see what it is, they can't say what it is because the language center is disconnected. So that's in the visual field. What about in the auditory field? We can do what's called a dichotic listening test. Dichotic listening test delivers different sounds to the ear at the same time. So people wear headphones, and you can present different information to the ears. So if you present the sound ma, let's say, into the left hemisphere or the left ear, auditory information then can go to the right auditory cortex, and back to the left. It kind of crosses over because we also have speech processing on the left. And you ask the person what they heard, and they say ma. If you present a sound in the right ear, again, and let's say we're presenting the sound pa, again, most of the information is processed by the contralateral hemisphere, so it goes to the left hemisphere. That's also where our language processing area is. They process the sound pa, and they say pa. But if you give them a dichotic listening test where at the same time you hear ma in the left ear and pa in the right ear, the information crosses, right? Like we said, most information is processed by the contralateral hemisphere. This pa information crosses and is processed by the language processing area in the left hemisphere, which is sort of our more lateralized hemisphere for language. And the person typically will say they heard the word or the sound pa. We say they have a right ear advantage. If you get two different sounds in two different ears at the same time, most typically people will say they hear what they heard in their right ear. They don't hear both sounds. They don't hear some kind of confusing sound. It's typically the sound they heard in their right ear. So that's the most typical, particularly in right-handed people. And then up to 50% of left-handed individuals show a reduced or a reversed pattern where they show no difference between the ears, or in some cases, a left hemisphere or left ear advantage. In terms of auditory lateralization, left and right auditory cortical areas play different roles. It seems, and we'll talk more about this, that the left hemisphere is specialized for language from birth. There is an area called the planum temporale. That's the upper surface of the temporal lobe, and you can see it right here. And it's typically larger in the left hemisphere compared to the right, even in infants before they even develop language. So we have this area that we believe to be very important in language processing, bigger in the left compared to the right. And this is where we say that the two hemispheres are very similar but not identical to each other. And we also know that damage to the left hemisphere results in people having less language than damage to the right. They lose language, and we'll talk about different ways in which language is affected after left hemisphere damage. Language lateralization is also coordinated with handedness. Most people are born right-handed. 10% of people are born left-handed or ambidextrous. 90%, it's interesting, of prehistoric drawings showed tools in the right hand. So perhaps people were right-handed for many, many years. Most chimps and other primates are right-handed. And for right-handed individuals, most people have left hemisphere dominant for language. It's a little different with left-handers. People who are left-handed have equal chances of left or right hemisphere being dominant for speech. And if the right hemisphere is dominant for speech, then the left hemisphere contributes more to spatial perception, which is kind of the opposite pattern. But we're going to talk about more the more common, much more common pattern of right hemisphere for spatial, left hemisphere for language. Auditory processing, though, is not all left hemisphere processing. We know that auditory areas in the right hemisphere plays a major role in the perception of music. Also, prosody. Prosody is the perception of the emotional tone in language. So when you say something in a tone of voice, which can totally change the meaning of the word, right? If I were to say to you, "Ooh, that's a really nice shirt," right? Or, "Ooh, that's a really nice shirt." The tone of my voice can totally change my meaning. That tone is called my prosody, and that is a right hemisphere specialization. So my understanding of the words is left hemisphere task typically, but my understanding of the emotional aspect of the words is processed in the right hemisphere. Right hemisphere visuospatial abilities. So lesions to areas in the right hemisphere can produce what we call visuospatial impairments. Astereognosis is the inability to recognize objects by touch. You touch an object and you can't tell what it is. Another interesting visuospatial deficit is called prosopagnosia, which we also call face blindness, and that's the inability to recognize faces, including your own face. Both hemispheres have some capacity for recognizing faces, and bilateral damage causes complete prosopagnosia. We think one of the important areas for face processing is what we call the fusiform gyrus, which is usually damaged in cases of prosopagnosia. When people have prosopagnosia, it's not as though they can't see. They can look at a face and see. They can say, yes, this person has brown hair and blue eyes, and they have high cheekbones and a dimple in their cheek. They can see, but they can't recognize who that person is. They can't put the pieces together to recognize who that person is, even if that person is their mom, their dad, their husband, their wife, their child. And the only way they can end up recognizing the people is by other cues. So either by clothing, oh, I know that my daughter has that dress, this must be my daughter. Or by tone of voice, once the person starts talking, I know that voice, that must be my husband. But not just by looking at the face. Prosopagnosia can also be present at birth. In that case, we call it congenital or developmental prosopagnosia. And both types might be accompanied by other forms of agnosias. And agnosia means the inability to identify other items, the inability to know, agnosia. One way we can test hemispheric processing in the lab is to use the WADA test. The WADA test basically uses an anesthesia that is injected into the carotid artery to temporarily shut down one of the hemispheres. So in this example, it's in the right hemisphere. And so this right hemisphere is anesthetized, or not working temporarily. And when we do that, we can say, oh, look, the right hemisphere is shut down. This person is saying, I can still talk just fine, but I can't hold up my left arm anymore. So we know that the right hemisphere is not important for speaking because he can still speak, but it is important for motor control of his left arm because he can't do that anymore. So the WADA test can be used to experimentally understand which functions may be lateralized to which hemisphere. After left hemisphere damage, one of the more common outcomes is what we call aphasia, or an impairment in language. And this can be in varying degrees, from very mild to quite severe, and again, caused by usually brain injury to the left hemisphere. Different types of aphasias. We have a paraphasia, that's substituting of a word by a sound or an incorrect word or an unintended word. Most patients who have aphasia also exhibit agraphia, that's an impairment in writing, alexia, that's an impairment in reading, and apraxia, that's a motor impairment, difficulty in making sequences of movements. So it's often not aphasia by itself. You may get some of these other conditions. Two main types of aphasia. The first we'll talk about is called Broca's aphasia or non-fluent aphasia. And this is when someone has damage to Broca's area, which is right here, typically left frontal lobe. And when we have Broca's aphasia, that's a severe deficit in language production. So Broca's aphasia, language production, caused by damage to Broca's area, as I said, the left frontal lobe and other potentially cortical structures and substructures. When we talk about language production, that means difficulty pronouncing words, producing speech. It can be writing as well. What happens is in this type of aphasia, they're able to use nouns and verbs more easily than prepositions and pronouns, things like and, the, things that make your speech smooth and sound effortless. That is the problem. They can get their point across very often. It is hard. You'll see them working hard and struggling to get the words out, but the words they do get out are meaning words. And it basically ignores grammar and relies on inferences. So you can see this is a quote from someone with Broca's aphasia where they say, yes, Monday, Dad and Peter, which is his own name, and Dad, hospital, Wednesday, right, 9 o'clock, Thursday, 10 o'clock, doctors, 2 doctors. So you're getting this idea that on Monday, Dad and this patient went to the hospital. We can sort of tell this understand what's happening. We know that this patient is trying to tell you what's happening. They're having a hard time producing the words. Speech production, this is Broca's area, or damage to Broca's area. And many people with Broca's aphasia or non-fluent aphasia also have what we call hemiplegia, which is paralysis of one side of the body, usually the right side. And you can see that Broca's area is right next to our motor area, primary motor cortex. And so when someone has damage here, it very often leads to damage in primary motor cortex as well. And so people are left with some kind of paralysis. So this difficulty speaking and producing words, as well as paralysis. And because this is left side, then the person is dealing typically with a right-sided paralysis. Now, another type of aphasia is called Wernicke's aphasia. Wernicke's aphasia is named for the brain area called Wernicke's area here in the temporal lobe. So we've got frontal lobe for Broca's areas, left frontal, and then typically left temporal for Wernicke's area. And I have that here. Here's kind of an fMRI picture of Broca's area up in the front and Wernicke's here in the temporal lobe. Wernicke's area aphasia is also called fluent aphasia. This is caused by damage to the left temporal cortex in Wernicke's area. And this leads to a problem in language comprehension, difficulty finding the right word, difficulty naming objects. These individuals have quite grammatical speech, but it often doesn't make sense. They've lost their ability to understand or comprehend speech. They can pronounce clearly, their speech is fluent, their speech is rapid and quick, whereas with Broca's it is very labored and takes a long time. And again, here's an example of quote, someone with Wernicke's aphasia. Well, this is, mother is away here working her workout here to get better. But when she's looking, the two boys looking in the other part. One, their small tile into her time here. She's working another time because she's getting two. So it's said quickly, it's said with all the right pauses and grammar, but it just doesn't make sense. So with Wernicke's aphasia, the person seems to lose, and we think Wernicke's area is important for comprehending language, for understanding language. And without that, you get this very nonsensical speech. A global aphasia would be a total loss of the ability to understand or produce language and results from widespread left hemisphere lesions affecting all speech zones. The prognosis for language recovery is poor, and this aphasia is often accompanied by other neurological impairments. Again, if you look at the brain here, if you have a very large stroke that includes Broca's area, Wernicke's area, lots of other brain areas, that's more of a major stroke and a more difficult for potential recovery instead of just a small lesion at Broca's or Wernicke's area. The connectionist model of aphasia, this deficit says that you can have a disconnection between Broca's and Wernicke's area that leads to certain problems. That Wernicke's area over here decodes sounds and makes sense of words and transmits that information over to Broca's area so that you can actually speak, makes a speech plan, and then goes over to the motor area for you to produce speech. So you can sort of see, you hear something, first goes to the primary auditory cortex, then to Wernicke's area so that you understand what is being said, then over to Broca's area so you can make a plan for what you're going to say, the production of speech, and then you need the motor cortex to actually make the movements for your mouth to actually make speech. And lesions that disrupt the connections between Broca and Wernicke's, right here, this is the arcuate fasciculus. can lead to a disconnection between hearing and understanding and making a speech plan. And what we actually see in these types of lesions is what's called conduction aphasia, which is an impairment in repeating words or sentences. So if you say, I'm going to say a sentence, you repeat it right after me. Say, the two dogs barked. Well, they hear it, they understand it, but that information in the Wernicke's area, that arcuate fasciculus is damaged, and that information can never get to Broca's area, so they can't make that plan to then repeat the sentence. Brain imaging studies imply greater complexity. This is a simple kind of graph or model of what's going on, and the more we do imaging, the more we learn, the more we understand that language is even more complex than this, but this is a beginning model. And again, the more we learn, the more complexity we find. You can use transcranial magnetic stimulation, which is a magnet, a very strong magnet that you basically hold over a part of someone's head. And that can be used to simulate a lesion by disrupting neural activity for an hour or so. And so when they do that, you can see a research question is, how is Broca's area organized? That it's not just one area, that maybe there are different sub areas with different linguistic functions. And so using MRI and transcranial magnetic stimulation, they can activate or deactivate discrete regions within Broca's area. And what they found here is the anterior region appears to be important for semantic processing. So this front region, more important for understanding words. And this back posterior region within Broca's area, important for processing sounds, or we call that phonological processing. So again, the more we learn, the more complexity we find. In terms of the basics of language, the mechanisms of language seem to be pretty universal, but you must learn the forms of language in childhood. In terms of language, phonemes are basic speech sounds, and morphemes are simple units of meaning. Then you can assemble those into words with meaning, and then you get semantics. Once you have words, you can assemble them into meaningful strings according to syntax or the rules of language. What's pretty cool is at birth, babies can distinguish phonemes from any language, so the basic speech sounds. If you listen to different languages, you can tell that there are some languages that now as an adult you listen, you go, what is that sound? And you can't really make that sound. They're all different phonemes, and we sometimes can't even hear the difference. And if someone's teaching you a word in a different language, you say it, you think you said it correctly, and they say, no, you didn't, you try it like this, and you keep thinking you're saying the right thing, but you're not hearing the differences in those very unique phonemes. Babies, however, can distinguish phonemes from any language. It's like their brain is able to hear and learn any language. So here's that unfathomable, a word, the morpheme that's a unit, right? Simple unit of meaning, and that's made up, excuse me, of the basic speech sounds, the phonemes, n, right? Another morpheme, simple part of speech, I'm sorry, or simple unit of meaning is fathom, right, to understand, and that's made up by those 5 different speech sounds. F, a, f, and then the morpheme of able, made up of 4 phonemes. So how do we learn language? There are different theories here. The idea of language as a learned skill, that language development depends on exposure during a sensitive period or a critical period, typically before 5 years old. After this period of time, language can be learned, but more effort is required and different brain regions are used. So this is really a learning theory approach, that language acquisition follows the principles of reinforcement and conditioning, that you have to experience language, you have to learn language, and that conditioning and reinforcement helps us to learn language. So, for example, if a baby starts to babble, they start to say all different sounds, ba da la da ba da ma da la ba, mama, and they say that mama, which means something, and mama is there and gets so excited and rewards the baby, hugs and kisses and all sorts of things. The baby starts to learn, that was good. How did I do that? Right? And they start to babble again. La ba da ma ga da la ma ma. Oh, again, said mama. Right? And the mom is saying, wow, that was amazing. I have the best, smartest baby in the whole world. Hugs, kisses, and all of that. And eventually the child learns that, hey, those are, when I put those two sounds together, I get hugs and kisses from mama. And they start to say that word more. And the idea here is that language is complex, but it's learned. It's also imitated, right? You hear somebody, maybe an older brother, say, Mom, I want milk. And you see that the brother gets milk. Then the child goes, if I say milk, maybe I'll get milk. Again, this is all about experience and learning through experience. Some evidence for this is children learn pronunciation of unfamiliar language aspects of language better than adults. The earlier you start learning a second language, the better. The earlier a child has a chance to learn sign language, the more skilled they will become. If you don't learn a language before starting school, you'll never develop much skill. You guys probably know this yourselves if you've tried to learn a second language in high school. I did. And I am certainly not fluent in that second language. But the earlier a child starts to learn and is exposed to a second language or a third language, the easier it is. And there is evidence, case studies, particularly, we have a lot of information on a child named Jeannie. You might have heard of her in a Psych 101 class, a child who's abused and lacked exposure to language for many years, rarely ever learned to speak normally. And this is the very sad case study of Jeannie, the wild child who was abused and locked up in the basement of her home until she was about 10 or 11 years old and really wasn't exposed to language. And when she was finally rescued by the police and brought to Children's Hospital, they were wondering about teaching her language after she passed the critical period of 5 years old, because she was already, like I said, 10 or 11. And what they found is no, they weren't really able to teach her language. They taught her some, but it wasn't a normal, fluent kind of language, which goes to the idea that language is learned. You have to be exposed to language to learn it. However, there's another idea that language is innate, that this is the nativist approach, that language is genetically determined and that we have innate mechanisms that drives language development. This was a theory promoted by Noam Chomsky, that humans are biologically pre-wired to learn language. And some evidence for this is that children all over the world reach language milestones at about the same time. So this really isn't learning because we teach so differently. If you imagine countries of all different types all over the world, children don't speak when they're infants. They start making sounds at a certain age. They start putting words together and saying words at a certain age. That seems much more biological than learning. There seems to be a common underlying structure shared by many of the world's languages. And Noam Chomsky had the idea of a language acquisition device, that there's a neural system in the brain that permits us to use language. Why do we use language in such a complex way and other animals do not? Now, this was years ago, now we do know that neuroscience research supports brain areas that are specific for language, just the ones we talked about, Broca's, Wernicke's. And we also can see that language has a genetic component. Williams syndrome is a genetic disorder that's characterized by various intellectual deficits, but these children have excellent verbal skills. And so we do see that there probably is some combination of the two, and that's we would call an interactionist model, that you need both things to happen. You've got to have the brain areas, the innate ability to learn language, and the exposure, that both of those things are very important when it comes to learning language. Dyslexia is a language disorder that can range from mild to severe, with a reading disorder attributed to brain impairment. You can have acquired dyslexia that we often called alexia, which is a problem with reading, and this would be a sudden dyslexia after brain damage, usually to the left hemisphere. You can have a deep dyslexia. Patients read one word as another related word, or a surface dyslexia where patients are restricted and they can only use the regular sound rules of the letters. They can't kind of figure out when sounds are different. Letters make different sounds. The dyslexia we typically, you might have heard of, developmental dyslexia. Again, this is unique to written language. It's not a cognitive deficit. This is when children are born with this problem with reading. It's a specific impairment of reading. Children have adequate vision, adequate skills in other academic areas. Dyslexia is more common in boys than girls, has a genetic basis, and different types of dyslexia may have different genetic bases. Excuse me, dyslexia is more common among English readers, partially due to the many odd words in our English language, like phlegm and khaki. Those don't look at all like perhaps they sound, and so reading may be a little bit harder in English. The problem seems to lie in connecting reading with the brain mechanisms for speech. Dyslexia has also been associated with neurological abnormalities. They have all sorts of different interventions for children with dyslexia. One of them is showing only one word at a time when a child is reading, so they can really focus on one word, take their time, not go too fast. So if you can imagine like a cardboard piece of cardboard with a one word kind of rectangle cutout, and they would move that along the page as they read. So you only see one word at a time and work on decoding one word at a time. And after using that in one study, the children didn't need the special cutout after 3 weeks of this intervention. So it is something children can work on and get better at. Recovery after damage in general, recovery of function is the recovery of behavioral capacity following brain damage after a stroke or an injury. This is what my research is on. I think I talked about this a little in the beginning of the semester. My research is on plasticity, neuroplasticity, and the ability of the brain to recover after early childhood stroke. Your book in this section talks about a concussion, a closed head injury caused by a jarring blow to the head. So hit in the head, or you're in a car accident and you get this closed head injury, meaning there's no blood, the skull isn't broken or fractured, but your brain is damaged kind of inside the skull. The inside of the skull is very bony and very sharp, and if your brain is kind of knocked around, you can have brain damage or concussion from that. Also, chronic traumatic encephalopathy, CTE. This has gotten a lot more notoriety, perhaps. It's in the news more often as the dementia that results from too many blows to the head. We talk about this in football. Football players after a long football career we're starting to see and be able to diagnose this chronic traumatic encephalopathy. It's characterized by excess tau protein within the neurons, which interferes with their function. So how do people recover after brain damage? Damaged neurons can sometimes regrow through collateral sprouting, meaning that like another side kind of sprout grows out of the neuron and maybe creates a new synapse. The use of embryonic stem cells for brain repair is promising. These undifferentiated cells can develop into the type of neuron needed under the control of local chemical cues, so there's research there. A recovery from brain injury depends on the passage of time. Typically, over time, people get better. The age of the patient, typically younger patients are better able to recover than older. The type of therapy used and the cause of the injury. So there's a lot of different factors. I will say that doing a lot of rehabilitation is key. From the research. Use it, practice, and it is so hard in the beginning. Someone's had a stroke, they're paralyzed on half their body, they feel like they'll never walk again, and using that part of their body, strengthening those neural connections, finding your brain, finding a way to create new synapses is extremely important. So doing a lot of rehabilitation, again, younger better than older, and time, because also right after a stroke or an injury, your brain is not only has, let's say, suffered a stroke where part of the brain has died, but just like any injury like that, the brain is swollen. Think about if you get a big bruise on your leg, your leg is swollen. It's got a lot of extra fluid. There's lots going on, and so over time, the um, the swelling and all of that goes down, and you'll see some increases in function just by that part going away. You still have to deal with the injury that's left from the stroke, and depending on the stroke, the cause of injury, how extensive the injury is, that also will determine how well someone will recover. Lesion momentum is important. Patients experience less impairment, perhaps when lesions develop more gradually. And then in terms of recovering function and therapy, this is one of the ideas, one of the ways that we help patients who have had a brain injury or stroke. Restoration of function and compensation are different. So sometimes patients practice a compensatory behavior that can reduce the impact of a brain injury. So if you are right-handed and you are now paralyzed, you had a left-sided stroke and you're paralyzed on your right hand, but you learn to sign your name with your left hand and brush your teeth with your left hand, well, that's a compensatory mechanism. That means, okay, well, it's still my right arm is paralyzed, but I can do more things. I have kind of reduced the impact of my injury because I'm learning to use my left hand. But we do see that stroke victims can regain the use of their effective limbs again. So what about if we can help you use your right hand again? And that's if they're forced to repeatedly use them. One of the ways we do this is called constraint-induced movement therapy. That's what's happening here. So this person looks like their left hand is the one they're working on. So he must have had a right-sided stroke. They constraint-induced, meaning can use the right hand, no problem, but they have put a glove and they're holding this right hand down so he can't use it. And they're asking him to do something like move these colored rings back and forth over this plastic tubing, only using his affected left hand. And so with practice, and in the beginning, it might be impossible. Maybe he could move it up an inch over here. But with practice and over time, and it's hard work, patients can start to perform the task with the arm that used to be paralyzed. And this is constraint, right? They constrain the hand or the leg that is working and make you use the affected arm. And over time, we see great progress in these patients, which is pretty exciting. All right, thank you very much.